So I'm going to come back to you, Roger, in a little bit because I want to talk to you about equipment, but it segues very well into Yehia's talk on where Radial fits into the peripheral vascular space. And I think more importantly than that, where are the deficiencies in terms of equipment? And I think it's a really important point because one of the things that industry have definitely failed us in is getting us adequate equipment in an expedient time. So it's frustrating for me as a radial operator to still be working 5 years down the line where we don't have long enough catheters, long enough guide catheters, long enough balloons, long enough stents, equipment that you would have thought wouldn't be that difficult to do or to manufacture. But for whatever reason, industry just seems to not have looked at Radial as a realistic access site for patients. So moving on to Yehia and just talking about some of the equipment that we need in more advanced cases and where you think the deficiencies lie. Interestingly enough, as we've been talking, I realized that all four of us sitting around the table are pretty much responsible for training radiologists all over the world. Damien trains in Manchester and trains a lot of the UK and Europe. I train in the US and in Europe as well, and Roger trains in Europe as well, and then Yehia is responsible for training interventional radiologists in Australasia. So it's a really unique situation for us to be in, to have all these radial trainers. But again, I think it highlights the experience around the table. So Yehia, just talking about more advanced radial intervention. Firstly, I guess my first question is, in terms of unstable patients, so bleeding patients, whether it be trauma, GI bleeds, anything where a patient is unstable, is radial your default? If it isn't, why? And if it is, why?
Yeah, in terms of stability and instability of patients, there's a number of scenarios that you have to consider. Okay, so for example, there could be an unstable patient during the day with an experienced radio operator, and everybody buying into that, and that works out really well. In other times, it might be in the middle of the night. You have people being called in. They're not really, they may or may not be familiar with radio access, and that will impact which patients you do and when you do them. So those factors are definitely something to keep in consideration first and foremost. Then the other sort of factors to be considered are patient-related factors. So what kind of unstable patient do we have? So because we're a major trauma center, we've come across a number of trauma-related patients who are unstable. So whether that be pelvic or visceral bleeds. Okay, sometimes it's in the chest as well. So we've had a couple of those as well, but mainly pelvic and visceral bleeds. And so those patients have the added complication of being hemodynamically unstable, having anesthetics involved, having blood products being given, and in that space they have tissue damage, and the blood products that they're being given all contributes to an induced coagulopathy.
Yeah.
Okay. So those are the sort of considerations that I have in my mind when I come across especially a trauma patient, but any unstable patient in general. The other consideration is when patients have pelvic trauma and they have a pelvic binder on.
Yeah.
Okay, so with the pelvic binder, that can make femoral access very, very tricky, especially if the hematoma extends within the groin, or if the patient's been given a lot of fluids and they have a diffuse edema. So that all those factors come into play when we're talking about unstable patients. Now, in terms of the feasibility and the equipment that we use, well, we know that we can get into the pelvis because we do UFEs and PAEs. Mm-hmm. So we know we have the equipment to be able to get to most of those vessels. Yeah. There is a length problem, I feel, especially with microcatheters, being able to get out. If you have, for example, a pseudoaneurysm in, for example, a superior gluteal artery, you may not be able to get all the way into, that pseudoaneurysm. And so I feel that, the equipment length, and as you feel, I feel very disappointed by industry to not push the lengths further and further. Yeah. And I think what really needs to happen is that there needs to be a standardization of equipment. So just like you go to your shelf and you pick up a burn catheter or a SIM or a C2. It should be just standard on shelf. We have the lengths to be able to get to wherever we need to get to.
Yeah.
We don't have to MacGyver things. We don't have to beg cardiology or any other specialty to kind of give us guidance on guide caths or sheathless guides or long sheaths. It should be a standard of care. And I think with that, the mentality of interventional radiologists and neurointerventionists will change.
Yeah. So do you think if we had more equipment or better equipment that was more suited to a lot of the cases that we do, that you'd get more buy-in from interventional radiologists and neuroradiologists?
I think that's without a doubt. Without a doubt.
Yeah.
I mean, one of the main barriers, if you like, or challenges that I find is that when we are discussing cases and we say, for example, we want to perform a renal angioplasty and stent insertion. Well, okay, well, do we really have the lengths? Do we really have the sheath sizes? And it is feasible, but it's not standard. And it's oftentimes, like I said, you're going up to the cardiology lab and asking them what they use and what they have, and extending, for example, guide caths, which I don't believe is necessary.
Yeah.
There should be the lengths available.
Yeah.
And I think in some spaces they have tried, some companies have tried to push those, but they haven't been available, and they haven't been available worldwide. Yeah. And I think that's a real big challenge that needs to be overcome.
Yeah. So, talking about that, if you had to, say for example, you went into work, tomorrow, and you had an SMA stent to do. I assume you would probably do radial as a default.
SMA stent.
An SMA stent.
Okay, so this is where the issues come up. Yeah. Okay, so I would come and say, I think we should do this case radial. Yeah. I might have another consultant or attending at the time, and then we'll have a discussion about whether or not it's feasible. We're able to get to the SMA.
Yeah.
Obviously wires are a little bit less of a challenge. Yeah. But proper length sheaths are a major issue. Yeah. So we still don't have, for example, a long enough sheathless guide to be able to get comfortably with the SMA. Yeah. So it may be possible, but for us to get into the case without proper planning, I personally really do not like that. Yeah. My personal view on cases is you should have a really good idea that and you're going to achieve what you want to achieve, and you have a number of fail-safes. Yeah. But this is the problem that we face on a day-to-day basis. Yeah. So, Terumo has some equipment that's longer. Their radial to peripheral portfolio is a little bit longer. They've got a 6 French long sheath, the slender technology, which is I think 119, 149 centimeters. Yeah. But again, it's only 6 French. There's nothing smaller than that. And again, if you look at in the cardiology space, almost everything that they do, bearing in mind that they work in the coronary artery, which are much smaller, but the manufacturers in the cardiology space have really done a lot to decrease the profile on almost all of their equipment, which again hasn't been done in radiology. I mean, look, low profile equipment and good transition between wire to microcatheter or wire to catheter to guide cath, guide cath to sheath is vital when we're working in this space. Yeah. I mean, and the trouble again, the issue is availability. So even though those products may exist in some parts of the world, they don't exist in all parts of the world. They're not available in all parts of the world. And even discussing with various reps from industry, they find it hard to justify. And even though I don't think the principle of if you build it, they'll come works in all areas. No. But I think in this space, if the products are available, people will take them up and will use them without a doubt. Yeah. And I've seen that with my own eyes, where people have used femoral access years and years and years. They've come, for example, to our courses, they've trained, and then they go back and they say, I do almost everything radial now. Yeah. And the only reason why they don't do everything radial is because of availability of equipment. Yeah,
absolutely. And I share your frustration, because it's a massive frustration for me as well. And I think the biggest frustration for me still today is the inability to reliably work below the inguinal ligament for cases. And simple stuff. I'm not talking about doing, complex CTO work. I'm talking about a straightforward angioplasty of the mid-SFA that you should easily be able to do from the radial, because you're not worried about pushability or crossing catheters, anything like that. And that's a frustration for me. In terms of the balloon in the knee, I think there's a number of scenarios where coming from the top or coming from a radial access has a huge advantage.
All right.
So is there a need? I guess my question is there a need to be able to go below the inguinal ligament from the radial in terms of peripheral vascular disease?
Yeah, look, I think there are a number of scenarios where radial access would be preferential.
Yeah.
So in general, the ability to have exquisite hemostasis is such a huge advantage over everything else, really. Yeah. So that's number one. Number two is, related to that is that patients are often primed with antiplatelet or anticoagulation. So already you're putting the patient at risk before you even start the procedure. Yeah. And that will be the same when it comes to visceral stent insertion as well. The ability to have immediate post-procedural mobilization for these patients is a big advantage.
Yeah.
It's a huge advantage.
Well, just before I'm going to interrupt you there.
Sure.
You and I had that interesting experience when I visited you in Australia, where we were training one of your neurointerventional colleagues to do diagnostic cerebral angiography. He had done 2 cases, and then his third case, he went and told the patient that he was going to have to do it femorally because he was running late because, as Roger had said, these things take time, especially when you're learning. And the patient actually refused to have the procedure done femorally because the patient saw the other 2 patients who had their cerebral angios done via the wrist and refused to lie flat for that period of time. And so, again, sorry to interrupt you, but it just highlights, again, we sometimes forget about the importance of the patient. The patients prefer it because it's better for them. They get up, they move around straight away. Sorry to interrupt you, carry on.
No, but that's one of the things that really highlighted the use of radial. And I think from then on, so segueing from what Roger was talking about earlier of how he started the neurointervention. Yeah. So our guys, I had been in discussion with them about starting the radial program for the neurointervention. And at one point, they just decided, okay, it's going to be this month we're going to start radial. So it was Radial September. And that happened to coincide with one of the courses we're running. So we just did Radial September. And then we got in there, Dr. Klaas and myself, we were helping them out to get started with that. They just got started from that month, and they just kept going from there. And basically we haven't turned back. Yeah. And it allowed for cases where femoral access had a failure. And there's been a number of cases where they have actually failed from a femoral access and then have moved to radial, which is, it's counterintuitive to what we usually think about in terms of crossover. We typically think of crossover from radial to femoral, but they crossed over from femoral to radial on a number of cases. So it's interesting that experience is shared in different centers.
But you also raise an interesting point, because again, another fallacy is this very high crossover rate from radial to femoral, in early experience. But I don't know about you, but Damon, did you find that in your practice? Did you have a very high crossover rate?
No, my last crossover was my third case, and I think that was just due to I think there is a learning curve. Yeah. That's unquestionable, but. I think once you have that learning curve under your belt, and it's maybe 5 to 10 cases to just get a feel for it, just to not be fearful of the need to crossover is a huge thing. Yeah. Our second case was a crossover. And that could have been a point of failure because you may have gone, this is my second case, I'm not doing radial anymore. Yeah. You have to engage. Yeah. It's like spasm. There's a massive fear of spasm. Yeah. What am I going to do if I get spasm? You have to accept that you will get spasm at some stage. It's going to happen, and you just have to deal with it, and there are mechanisms for dealing with it. Yeah. And as long as you realize that at some stage I'm going to have to cross over, at some stage I'm going to have very serious spasm, at some stage I may cause TIA or something, and if you do enough cases, you'll have these issues. So it's recognizing that fact.
Yeah. Roger, have you had many crossovers, or do you still have some patients where you just have to cross over to femoral, or
We reviewed, I think it was the first 150 patients, and it was just in 4 cases. 2 of the cases was for arterial lusoria that you didn't know till you arrived. That was the first 2 cases, but we found that 2 other times, and the next 2 times we have been able to catheterize.
Ah, okay. Even with an arterial lusoria?
Even from the...
Just so, yeah.
Yes.
Yeah.
I mean, it's just 4 cases. Not that common, but the first 2 we couldn't, and the next 2 we could. And the other thing that maybe we can have a bias for that, of course, if there's if we don't palpate properly the artery, we ultrasound and it's 1 millimeter, we just don't go radial.
Yeah, absolutely.
So probably that's another main thing. There are some cases that we just haven't done them.
Yeah, yeah.
And probably we have encountered a lot of spans, we just get femoral. So that's probably explains also the good numbers.
Yeah.
I think patient selection is massive.
Yes.
So in our only crossover case to date, we crossed over to femoral and we failed femorally.
Femoral as well.
I think in retrospect, had we seen that patient, we would have gone, we'll maybe try femoral first because the aorta was very hostile.
Yeah.
And patient selection is key for everything. You have to plan, prepare.
Yeah. I mean, generally, what I've started to do in a lot of those cases where you have elderly patients, unfolded aortas, is I use a coronary guide catheter, 5 French coronary guide with a 4 French diagnostic 125 through it, just to give you a bit more ability to talk in the aorta, and I found that works pretty well. You do this.
That's a good point. I mean, just the other day I had one that was just horrendously tortuous.
Yeah.
And just got around the arch and then went through with the guide cath, which gives you a nice stiff talkability. Yeah. And then it worked out well from there. Yeah.
So here just to kind of end off. Again, going back to peripheral vascular disease and equipment, where do you think the deficiencies are? And you can be as specific as you want. What do we need? What does industry need to concentrate on in terms of longer lengths, sheaths, stents, balloons, whatever? You know, what do they need to look at?
Look, I think it's everything really.
Yeah.
You need to have long sheaths, get down the arch. You need to have long guiding catheters. The way that I see peripheral vascular treatment is going to be like a multi-axial system. Yeah. So you're going to go from sheath, guide cath, standard catheter, micro catheter, and then wire. Mm-hmm. And so you're able to cross any of those lesions that require crossing. You need to have some really good low-profile balloons and low-profile stents. Balloon expandable stents are also, I think, are very important as well. And then with the balloon expandable stents, you're able to open it up to nominal, and then you can come back with a larger balloon and open it up to a bigger diameter if required. But the lengths, once we have longer sheets as well, that'll give us that stiffness across the arch, so we don't have to keep going back and forth. So I mean, those are the sort of things that really are required.
So I mean, I guess longer length, lower profile is pretty much the message here. So another question, if you had to sit down with any manufacturer and they said, right, we're going to design a low profile stent, a low profile balloon on a 200 centimeter shaft, do you want it rapid exchange or do you want it over the wire? What would you go for? Do you think we need the 450 centimeter wire that we have, or do you think we can get away with a lot, like as cardiologists do, with a rapid exchange system?
Yeah, I think we can get a lot away with the rapid exchange system. There's a lot of 014 and 018 balloons that we use via femoral access that are rapid exchange. There's no reason why we can't use them via radial access. Yeah. Absolutely not.
Yeah, I agree. And Roger, from your point of view, in terms of neurointervention and equipment, where do you think that, because there must be deficiencies in the neuro space, there's got to be, where are they? And what do you think the manufacturers have to look at from a neuro perspective to be able to do some of your cases?
So maybe we don't encounter the problem with length, but sometimes, as you said, as you're going more coaxial, the sheet normally the length is okay, but as you go for intermediate catheter, the micro, sometimes you encounter some difficulties. So it's important to have longer micros. The other thing, it's mainly the diameter, no? Doing thinner. So we have this slender technology from Terumo or Merit. So, but these are still for short sheets. Yeah. We don't have it for long sheets. And probably when you have a long sheet in the radial artery, you get a lot of support. So probably the wall of the sheet can be thinner than from a femoral one.
Yes.
So this is a thing, it can be improved. And the other thing, as you said before, is also the transition. We are using sometimes sheetless techniques, using a dilator, but maybe it's not the same as going from femoral from the radial, so have to be really prompt to don't injure the artery. And the other thing, as you said, there may be some material available, but sometimes it's difficult to get in your own hospital or on your system. For example, we have very simple thing. To get long catheters, longer than 100 centimeters, sometimes it's difficult for some shapes. And I know there are in the market. But for this simple reason, sometimes we fail and I'm not using Radial because of that. So this is another main thing. So, but I think it's just thinking all the materials we have, most of them can be used, but no one has thought of materials to do proper neuro. So probably the transitions also. Many sheets or intermediate catheters, the transition zones are thought for femoral and not for radial.
Yeah.
So I think, yes, we still need some improvements, of course, to make it more popular.
Yeah, I agree. So we've been talking now about some advanced techniques in the radial space. We talked a lot about the distal radial intervention or snuffbox access. We've spoken about the advances in the neuro space, and I think some of the really good points that were highlighted, firstly, is good training. I think the other thing that was highlighted was not to pick difficult patients to start with, but to choose your patients well. Patient selection is absolutely key, whether you're starting from an interventional radiology perspective or a interventional neuroradiology perspective. I think it's absolutely key to choose the right patients. More importantly than that is know the equipment that you have and know the equipment that you need to be able to succeed in doing your cases. And I think we have a long way to go when it comes to equipment, and I think industry is obliged to look into the radial space because it's better for patients and to develop that technology, because there is the technology out there. We have slender technology, we have technology that exists with low profile stents, low profile balloons. And what industry needs to do is to look at putting them onto longer shafts so that we can do the cases that we want to, because at the end of the day, we're all sitting here because we believe in radial. We believe in radial first, not necessarily radial only, and we believe in that because we think it's better for patients. So I'd like to take this opportunity to thank Damien, Roger, and Yehia for giving up their time to talk to us today about radial intervention. Thanks very much, and thank you to Radcliffe Vascular.